Thank you, Ray, and thank you to the TVS for inviting me here today. I represent the NHS England Improving Wound Care Project Board, and last year Kath Evans presented some of the initial work that had been done with this group. And today I'm hoping to improve this and update on the achievements and the plans for the future. The lead for the Improving Wound Care Project Board is Margaret Kitchen, who's the Chief Nurse for Yorkshire and Humber. So how this all started was really with the Burden of Wound study. And in a lot of ways, the Burden of Wound study achieved its objectives in terms of raising awareness, raising the profile of wound care, and stimulating debate. And the ongoing publications built on from the original study include a higher population, and there's some further publications in press. But what this did was highlight areas for improvement, and I've been working with the NHSE on the board to address as many of these areas of concern as possible. And these vary from very clinical issues such as assessment, treatment, multidisciplinary team involvement, but also the cost of care and services and service delivery. But we've got to put this into context really, and NHSE is NHS England, and we work within the UK. So this is applicable to NHS England only. But the original issues identified in the Burden of Wound study apply to the UK generally. The NHS England work stream has placed this work under Leading Change Adding Value. And Leading Change Adding Value fits very comfortably with wound care because it looks at improving the health and well-being, care and quality, and funding and efficiency, and targeting the reduction of unwarranted variation, because there is a variation in practice across England. The commitments of Leading Change Adding Value, as I say, fit very, very tidily with wound care, but it has to be said that this is a nursing initiative. And wound care isn't just nursing, even though it's predominantly led and performed by nurses. So let's look at the wound care, Improving Wound Care Project Board. And these are the work streams that have been progressing throughout the year. And I'd like to give you an update of what's been going on and updates in terms of these work streams. The first, I'm sure many of you will be aware of, is the sequin and the wound assessment sequin. And this is mandatory for community providers. And the goal of this really was to look at increasing the number of full wound assessments for wounds which fail to heal for 4 weeks. And this really was to target improving earlier assessment, so we get more appropriate treatment early on in the phase of healing, so that hopefully the outcomes will be improved. And we didn't really want to look at just healing rates per se, because we all know how difficult that is. The denominator for the sequin of course, those wounds that have failed to heal in 4 weeks, but following self-care, primary, community or specialist care. So any wound that has failed to heal in 4 weeks. And of course the retrospective audit, which is done 6 monthly, of 150 patients that have failed to heal within that 4 weeks' time. And we're collecting data at the end of Q2 and the end of Q4. And the targets have been set for this year. And of course we've just been in the initiation phase up until now. And we're collecting data. And by the end of Q2, it's anticipated that 60 to 100% of all patients will have a full wound assessment to achieve full payment. and at the end of Q4, which is April next year, that increases to 80%. This is quite a stiff target, particularly as all the full wound assessment indicates that all the factors on the minimum data set will be included. Which brings me on to the next work stream, which of course is the minimum data set. And Suzanne Coleman presented the methodology to achieve the minimum data set last year at this conference. So you're probably all familiar with its contents by now. But bearing in mind this is a minimum data set, and it's hoped that from this data we can expand this to make it more applicable for specific wound types such as pressure ulcers, leg ulcers and diabetic foot ulceration. Suzanne published this work in the TVS journal, and of course this is ongoing work with the work stream. From the burden of wounds study, there was more than 41% of all the wounds were on the lower limb. And perhaps this lower limb work has been overshadowed somewhat by the pressure ulcer work. And Brenda King is leading on this work and has published her work stream work in the Wounds UK journal. But there's much to do in this work stream, and Brenda is looking at aligning this with the Legs Matter programme. And this work so far has highlighted these key points. And a lot of it is around commissioning of leg ulcer services and audit in terms of, do commissioners know how many leg ulcers and what their outcomes are, and care settings and pathways, and sharing information across the pathways so that we all have and are using similar information. And basically trying to find out what a good service looks like so that it can be used and replicated for other areas. But part of this is fundamental, is the requirement that staff are knowledgeable and skilled. And to ensure that staff are knowledgeable and skilled, we need formal and informal education and training. So one of the work streams has been looking at a framework for wound assessment education and competency. And this is hoped to rather standardise training and education, which currently is a bit variable across the country. Needs to try and make it more accessible to staff, but also linked to competencies, so we have knowledgeable and skilled and competent staff looking after our patients with wounds. And this framework provides expected levels of competency for each staff member working in wound care, and it's fundamental to providing a good, efficient service. A good service will allow cost savings and effectiveness. And Kath Evans last year presented Betty's story, and some of you I know will be familiar with Betty. But this provides an example of compared standard or poor care or poor service to an optimal service and pathways. And it's useful, particularly for commissioners, to see this example because it provides evidence for reshaping current practice and services, because informed staff can lead to quality of service, cost savings, improve outcomes. And there is a little YouTube video, which again, 5-10 minutes of your time is well worth looking at, and send it round to this link round to your commissioners, GPs, managers, whoever might be interested locally. And hopefully this then will start some discussion locally and stimulate questions. And questions that should be asked really locally is, how many venous leg ulcers are there locally? What are the healing rates? Who delivers the care? What is the cost? Is there variation across the local patch? And what are the barriers to good care? And what about the patients? Are they involved? Wound care is not often on the Commissioner's radar, but why isn't it? They're paying a lot for it, and why shouldn't it be? Is it because there's simply no information? And is there variance? Well, just to show an example of some variance across England, this graph looks at the spend of per 100,000 population on compression bandages, and just illustrates there is tremendous variance across England. You may see a highlighted one there that is about down at the bottom of the chart there, 4,962. I picked that one out simply because when we look at the cost of bed days from cellulitis and leg ulceration, we see that trust that is spending lower amounts on compression bandaging is actually spending a higher amount on bed days. Just one example. Not all the examples reflect this, but it does show a third more cost in inpatient stay. More information for commissioners and providers is our Workspace platform, and this is a useful place for collecting information and for everybody involved in wound care. And it is a base on which there are chat box, case studies, economic analysis. Betty certainly lives here. There's a working in partnership, research repository, sequin information, and therapeutic areas. And it's something that your commissioners and GPs might be interested in looking at, because hopefully we're going to build on the case studies and examples and place them in this area. I have the contact at the bottom of the slide there, Lee, who I would urge you to try and improve this web space and interact with it as being a vital part of information for the future. NHSE is working closer with NHSI, and I understand that the two organisations are going to be soon combined. And of course the NHSI has been involved in Stop the Pressure programme. And I'm not going to mention too much about this because I know that Jackie later today will be providing an update. But it's important that we align ourselves with all the other national activity. And the NHSE has been working alongside both existing work but also within new initiatives. And just to make sure that there's no conflicting messages and that we all are saying basically the same thing. And of these organisations, there's the Business Services Authority, Carter, and Academic Health Science Networks. And I know that Una will be presenting shortly on the Legs Matter programme, which of course we need to make sure that everybody's saying the same thing. Just to go through some of the information, the BSA strategy is that this is a large piece of work across all areas of care, but it's the Pacific team that is specifically looking at wound care. And they do understand that it's a complex nature on topic, and we need to understand that in terms of the impact of trying to save money from the benefits of that. And this team are driven by financial effectiveness, and the benefits in terms of savings will be put then back directly into patient care. So it's probably a good initiative. And how they're doing this is collecting information and data from existing information. So things like FP10 and the EPAC data, they're collecting information from that, collecting and coordinating case studies and getting a picture of what a good service looks like, and then working with trusts and organisations to review their individual challenges and support them through change. The other initiative, of course, is the Carter report, and we're also working alongside Anne Jacqueline, who is presenting an update of this tomorrow. And she will explain more fully how this project operates and hopefully some of the results. And again, they're trying to determine what good looks like in collaboration with the Pacific team and how organisations operate. There are 23 Carter cohort trusts, and these are mental health and community trusts scattered across the country. And again, this provides the information from the Carter report that I'm sure that you will hear more about tomorrow. The work by the NHSE and the burden of wounds has stimulated debate. And in November 2017, Lord Hunt asked Her Majesty's government what plans they have to develop a strategy for improving the standards of wound care in the NHS. Some of you will be familiar with this debate, but I will just go through some of what was said. The situation will only be turned around with a nationally agreed strategy to reduce variation, preventing wounds getting worse and improving outcomes. They discussed national care pathways for wounds that must be established to cover the complexity and variety of wounds. The debate went on to say that wound care should be seen as a specialist segment that requires clinicians with specialist training to diagnose and manage. It recommended community-based clinics and concentrating on prevention as well as treatment and healing. It also said that we should be using high-quality products in contrast to current skimping. So there was more emphasis placed on the cost of care and not too much on item cost, and it enhanced that and encouraged innovation, effectiveness, education and British suppliers that will provide us with high quality products. There is further debate planned. It was meant to be last week, but is now going to be at the 22nd of May. So we will await the outcome of that. So in conclusion, ladies and gentlemen, it is expected that there will be change, and the opportunities for improvement and defining guidance and process is afoot. And as for the group itself, we're hoping to complete the good practice guidance, particularly with Brenda working on the legals, but in wound care as a whole. We're continuing to work closely with NHSI, Stop the Pressure and Carter programme, and develop the project plan for a national wound care strategy. And the lead for this will be Margaret Kitching, supported by, of course, Jane Cummings, Department of Health, NHSE, NHSI, as well as ALBs. And we have change afoot, and we need to start thinking in terms of we have problems to solve We need new thinking. Thank you very much.
So we have time for 2 questions. Any questions? So microphone's on its way.
Hi, Alison for Accelerate. Thank you very much, Kath.
Hi.
Here. Just to add into the discussion around data and how difficult it is to get data, on the slide with the data on spend from the SBS, the interesting thing about that is it's only FP10 spend, isn't it?
Yes.
So whilst we have that data, it's spurious still
Yes.
because of the NHS spend is
Yes.
not part of that data.
Yes.
So I know that on the chart you had about compression, Tower Hamlets is way down the end because we purchase it through another route.
Yes, and we know that the data, and certainly BSA are aware that the complexity of this, but they're trying to use data that originate, that we already have.
It's in the public domain. Yes.
That's in public domain.
Yes.
And other data too, to make sure that we've got as much information, or they have as much information as possible, without coming to us to supply that information.
The problem with NHS supply chains, you have to do it through freedom of information.
Yeah.
And even individual CCGs, they've got so many different pots.
Yes.
So it's a frustration. It adds to our problems with not knowing our data.
And that's one of the problems, is that there isn't 2 areas where have got the same collection of data, so the data that is there isn't always reliable.
No.
As is those charts.
Yes.
Not reliable.
Yeah. Thank you.
One other question. From Jackie.
Hi, thanks, Alison. Just to say, if Anne's presenting tomorrow, I'm sure she'll present some work we've done with operational productivity, looking at how we've looked at whole system spend. So she's done a piece of work asking organisations how they split their spend.
Yeah.
Because as you say, some people spend primarily through prescription, some spend through NHS supplies, some use OnPOS or other commercial systems. So we have got a piece of work that looks at the whole system and how that's split out. And also why people go different routes, because I think that's important to know, why you choose the route you choose.
Yeah. Thanks, Jackie. Yeah, you're right.
Thank you very much.